My name is Heun, I'm a consultant psychiatrist. I would like to talk about the diagnosis of schizophrenia today. We have this series of mental disorder explained under Archives of Global Psychiatry, and we would like to give enough scientific knowledge and practical knowledge to people. Today we would like to help you diagnose schizophrenia if you encounter that. And so I would start with the symptoms, and usually it's nothing you can find in the blood. There's no tests available. It's usually that's based on the symptoms of the patient. And so usually it's an algorithm, or you can say it's operational criteria, and usually there's some subtypes, but I come to the subtypes of schizophrenia later. So at least one of the following should be in the ICD-10 diagnosis of schizophrenia. ICD-10 is the International Classification of Diseases. We will in the near future work with version 11, and there might usually be some minor changes. So, as I said, at least one of the following: thought echo, thought insertion, thought withdrawal, or broadcasting. That means thoughts a patient have can be echoed, can be put in by others, can be taken out by others, or can be spread into the environment, family, or the people who are on the street. There can be delusions of control. Other people control your movements, might influence or make you passive. Usually these delusions of control, influence, of passivity should be related to some movements or specific thoughts, but should be more or less precise by the patient. There should be voices giving commentaries of the patient's behavior. That's another criterion, or discussing him, or the voices might discuss the patient among each other and might talk about him. And usually it's quite frustrating. Usually these remarks or comments about the patient are derogatory or are perceived as derogatory and can be very stressful and causing anxiety. Usually patients find it much easier to talk about anxiety than talking about concrete, sometimes bizarre thoughts which they don't want to open up, but anxiety can be a starting point to get into a decent communication with the patient. And there might be some inappropriate delusions which might be implausible, and that might be, someone might feel that he's superhuman. I recently had a patient who felt that he is related to God, or he's God or godlike. He could rationalize about that, but he sometimes said he had understanding of the law, which we wouldn't have, and he would live and be above the law in Scotland or England, and wouldn't have to respond to the courts, which might be something they usually express in tribunal about community treatment order or any other legal problem they have to deal with. Right, then usually other criteria is some of these. There's also hallucinations in different type, visual and acoustic. Usually they can be precise, they can be formed, be mixed with delusions or have relationship with delusions. Sometimes they're overvalued ideas, and sometimes they occur every day of the week, but sometimes they only occur monthly, and sometimes you then have to decide whether it's worth to give an antipsychotic. Then there are breaks of interpolations or on the train of thoughts. Sometimes people might feel like blocked. They talk incoherent or irrelevant speech or have neologism. Incoherence means that the train of thoughts is not followed. Sometimes irrelevant speech means that they completely what they talk is completely irrelevant to the question or the issue which is discussed. And neologism is forming new words which have no established meaning. Some people might have catatonic behavior, such as excitement, posturing, or sometimes waxy flexibility. Sometimes they're mutistic, negativistic, and stuporous, so they don't answer and might walk around in the room or might stand in the room, sometimes in weird postures. But I think that's quite uncommon, but you find this very common in depiction of schizophrenia in the first part of the 20th century. What's very common is that people who have schizophrenia have negative symptoms, such as apathy, they don't speak much, they have a blunt effect, so if anything happens, they don't enjoy joy, but they don't suffer when they see something. So sometimes the emotional responses don't even fit to what is shown, which we call incongruity of emotional responses. Sometimes you have changes of the personality and the behavior, which is usually a lack of interest, aimlessness, idleness, and self-absorbed attitude. That's something we have seen in this guy who was godlike. And very common is social withdrawal, and usually these symptoms have to last for at least 1 month. In the ICD-10, there's subtypes, which is paranoid schizophrenia, where the main symptoms are delusions and hallucinations. Hebephrenic schizophrenia, which appears in younger people, where disorganized speech and disorganized behavior, sometimes silly behavior, making inappropriate jokes, laughing when nobody else laughs. So that's a bit disorganized. Sometimes there's an inappropriate effect, as I said, or a complete flat effect. Catatonic behavior, schizophrenia, is that when psychomotor disturbances become in the foreground, so people are very stiff, they don't move, or when they move very repetitively. Undifferentiated schizophrenia is when the general criteria are met, so hallucinations, negative symptoms, and some delusions are there, but there's no symptoms which really predominate. They're usually very common in schizophrenia as post-schizophrenic depression. Usually when people experience schizophrenia, they very often have long-term depression as part of the symptoms. Residual schizophrenia is when people have usually a type or had a type of paranoia and hallucinations. These are gone, and then they're usually negative symptoms. Negative symptoms are symptoms people have no interest, no drive, no motivation, they're idle, they sit around, do nothing. So this type is then very often seen in these large institutions where people do more or less nothing except smoking and sitting around and not even properly communicating. Right, there's simple schizophrenia, which is more or less a secondary or defect state of residual schizophrenia, where the initial paranoid hallucinatory phase was missing. Okay, I hope you liked this video and learned a little bit. So you have to tick the boxes. The symptoms have to be severe enough to affect the life of the people, forgot to say that. And there are different types of symptoms which are included in these type of operational criteria. Thanks for your interest, and if you want to see more, please let us know or subscribe to our channel, Global Psychiatry Archives. And thanks for your interest. Bye-bye.